you to help me build the most efficient, safest, fastest car. On top of that, you have unlimited funds. Let's say if you, in this group, in this table, were to go out and find the best brakes, you find the best transmission, you find the best chassis, and so forth, pretty soon you can come back in a couple of months and say, you know what, I got the best brakes from Porsche, you got the best chassis from BMW, you got the best Volvo seats, and you can bring all these raw parts in this room, correct? Then you get the best engineers in the world. How long do you think it'll take to make the best, safest, fastest, most efficient car? 6 months? A year? 6 months. How about 2 years? How long will it take? You got unlimited money, the best technicians, best mechanics, and the best parts, all in this room. 5 years from now, all you will have is a pile of junk, right? Because nothing's going to talk. There's nothing, none of these parts talk, and that's what healthcare system feels like today, right? You have the best surgeons, the best oncology medications, the best antibiotics, you know, over 6,500 drugs you can write right now, best CT scanners, but nothing talks. It's the system delivery that's really failed, and that's exactly what it is today. So you would think with all the stuff that we have right now, we should have the most efficient, cheapest, economic healthcare system, but we don't. And obviously, we lack systems, and that's where the problem is. We don't lack resources. We have the best resources available. We truly do. I mean, there's countries that lack resources but get better results because they're just more efficient. That's, you know, we'll disagree. We're in the middle of a healthcare crisis, right? There's no country in the world today that's not asking this very question: can we afford healthcare tomorrow? Right? It's a true question. I mean, the healthcare cost goes up double your normal inflation. It's probably the #1 cost for any medium, small size employer in the country. You know, they're not worried about electric bill, they're not worried about, you know, HR, they're worried about what the medical cost will be next year. Because it's just scary. And, you know, it's not about cost either. I know there's no money, there's no mission, I get it. But it's not about cost. It's also about safety. It's about quality. You know, if you would think if we're spending gazillion dollars like we are, you know, 18% of our national product a year on healthcare, we should have something that's more safe and economically available. So, you know, you guys were talking about health insurance. In my mind, you know, I chuckle. We don't have health insurance. We have a health plan, right? And the problem is our patients, the consumers, think they have insurance, so they use a card just like this, swipe, 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 because they don't care, because they don't see the bill. Really, it's a health plan. We don't have health insurance. We truly don't. It's like, I always tell my patients, you know, if you have State Farm insurance for your car, you don't go to State Farm when you need to replace your tires and do an oil change. You know, that's out of pocket. It truly is out of pocket expense. And we don't look at it that way in the healthcare. We want everything paid for. And I think a lot of it is just educating the consumer. So healthcare system is 3 things, and only 3. One is the delivery of care, meaning the doctors, the hospitals, the nurses, and so forth, right? That's the floor. That's what I put on the bottom here. That's the floor. And if you go on the left-hand side, it's basically all the smaller services. On the right-hand side is the ICUs and the surgeries and open heart surgeries and so forth. So you have a continuum of cost from left to right, correct? So, you know, the wellness programs in the clinics and the primary care doctors are on the right-hand side, or left-hand side. On the right-hand side is the surgery. So basically all of these services cost more and more as you go to the right side. Okay? Then you have the consumer sitting and getting direct access to anybody. They can go directly to a dermatologist today. Do they need to? Probably not, but they do. So they don't have to go to the primary care. They go wherever they want. They go straight to the ER. The primary care doctor doesn't even know about it. I have patients that die in the ER, and the primary care doctor will never get notified because the system just doesn't talk. It doesn't talk. Then you have the payers, you guys, meaning your clients, right? I mean, whether it's commercial, whether it's Medicaid, Medicare, or it's self-funded people. Whatever that may be, someone's paying the bill on top. So when you start looking at this system, what's missing? Communication. What's missing? There's one critical piece I left out. On the bottom, the platform is the electronic medical record. So whoever thinks that electronic medical record was designed for patient information, I have news for you. It was a billing company that came up with it. And then everyone just sat on it and said, how can we bill the best CPTC code? That's what it was about. It's not about patient information at all. There's no billing company out there today that truly does patient records, none. So now you have a broken medical record system on the bottom that makes the foundation, and the entire house now is basically disjointed. Because the Siemens CAT scan will not talk to the EKG machine made by HP and will not talk to the Philips lab machine. Is it by choice, or is it by design, or is it just an error? What do you think? It's a design, okay? Walmart knows what size shoes I wear, right? If I get a pair of slippers at Walmart, they know what size, what color, which Walmart I took it out from, and how to place the order. My ER has no clue if I take a 38 French tube today for a chest tube, it's a mechanical count. Hopefully someone counted it right. Hopefully it'll be there when I need it tomorrow. And a lot of times it's not. Then you run around looking for it last minute. It's facts of life. So when you start thinking about this, let's say if I were to ask you, what is the third leading cause of death in the United States? What do you think it is? What do you think? Diabetes. She said hospital errors. Third leading cause of death in the United States. Is it cardiac? Is it drug? Is it strokes? What do you think? You get dessert. The third leading cause of death in the United States is healthcare providers. Healthcare workers make up the third leading cause of death, all right? And the truth behind it, I guess we knew about this in 1999 when IOM came up with this report and said, hey, you guys are like really messing this up. You know, it's like one jumbo jet crashing every day. That's what makes up the third leading cause of death. Now, you know, if a plane skidded off the runway, everyone knows about it. But every day, one jumbo jet crashes every day in the hospitals within the United States. We don't care. No one knows about it. So I guess the question is why? We knew about it in 99. 10 years later, they did another survey to find out, and we actually got worse. I mean, literally, 10 years later, 2011, they came up with another report. It was embarrassing. We got worse than what we knew in 99. So I guess my point is there's a lot of things that we do out of convenience in the hospital setting, I mean, or any healthcare system. I'm not knocking on the hospitals, any healthcare system. You know, if I work a 12-hour shift, the ICU nurse works a 12-hour shift. Is it by design or is it by choice? It's because there's shortage of nurses, so they call the shot. If you're in the ICU with your baby, you probably don't want to see the nurse at her 12th hour. Or me on the 12th hour. You want to see me on my 7th hour, right? But the point is there's shortage, so we go along with what is out there. I mean, you know, if someone says, I want to do 12-hour shifts, yeah, sure, go ahead and do 12-hour shifts. But we're the only country in the world that does 12-hour shifts in the hospitals. We're the only country in the world that has stools and chairs in the ICU. The lawsuits, most of the lawsuits occur when? When the ER is busy or when the ER is slow? What do you think? Slow or busy? It's actually when it's slow. You know why? Because half the staff, if not half, 99% of the staff is Googling what they're going to be doing this weekend and shopping online. And then a patient comes in, they're a disturbance. But when the ER is hopping, it's busy, it's 6 o'clock in the evening, that's not when the lawsuits occur because everyone is focused on work at that point. 2 million Americans get infections that they didn't have at the time of admission. 2 million Americans. Why? This guy here is having this sanitizing gel, right? 24% of healthcare providers wash hands between patients. You think it'll be simple, 24%. You think that number would be a lot higher, okay? You know, if you look at the orthopedic procedures, overall, my best friend's an orthopod. All right? But if you look at orthopedic procedures, 2% of the gross national product is equivalent to all the unnecessary orthopedic procedures. Not all the unnecessary orthopedic procedures. So if you just cut out that, you get 2% of savings right there on top. 60% of asthma patients don't get the care they deserve. 60%. There's a town, we'll leave it nameless for a minute. It's 150,000 population. So they said, in this population, in this town, I want to know how many CAT scans were done last year. I mean, that's a simple question. How many CAT scans do we do last year? You would think it'll take a week to get that answer. It took about 6 months. Once we found out what the answer was, how many CAT scans do you think a city with 150,000 population, how many CAT scans do you think they had? Over 50,000 in 1 year. We have a problem, right? I mean, that's a problem. It's overuse. So, we can kind of keep going and saying, look, there's a lot of areas where, there's room for improvement. That 30% of spine procedures are unnecessary, 30%. 60% of CVA, stroke patients, they don't get the care they actually deserve. It's inadequate care. 50% of patients that get second opinion, 50%, they have a different diagnosis, different prognosis, or different treatment plan. 50%, second opinion. 70% of all second opinions have a different path that they would take. And, okay, so this is interesting. In 2002 to 2007 or so, the spine surgery, back surgeries went up by like 15%. Do you know why? Why do you think during that 5-6 year period, the surgeries for spine just went up? The reimbursement codes changed in 2002. All right? There's enough blame to go around, right? I mean, if you really look at this, is it the insurance company? Is it the patients? Is it the clinicians? Is it the hospitals? I mean, there's blame. Everybody can share. Okay? It's not one-sided. So all this time, the reason why we are here today and the mess that we're in is because of one reason in my mind. Is all along, we always talk about standard of care. It's like the standard of care, if you ask anybody what the definition of standard of care, they have all kinds of answers. Lawyer will have his version, I have mine, docs have theirs. But at the end of the day, what it means is the minimum care I need to do on you to stay out of trouble. That's what it means. Minimum care I need to do to stay out of trouble. So that's standard of care. So I set my bar right here. Once I set my bar here, I might fall short one day. I might not be on top of my game. So now I'm below standard care, and that's now becomes my contribution to the third leading cause of death in the United States. But if I had my bar here, one day if I'm not on my game, I might drop a little notches, but I'm still a little bit, I didn't mess it up. So I think we've been convinced that standard of care is all we need to do. And in your conversations, you'll be talking about the same thing. Did we meet the standard of care? I was a CMO of a hospital. All we talked about for that number of years, I was convinced that's all we needed to do, standard of care. If the doc met the standard of care, good to go. If he didn't, we can spank him, then he'll be good to go. But we can't fire him because the orthopedic surgeon makes $18 million for the hospital. How can you let him go? So what do you think were my incentives? I was telling you, I was working in the ER quite a bit, I still do. What do you think was my incentives? I managed 14 contracts. What do you think was my incentives? Quality? It's Disney World, guys. It's Disney World. Click, 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 click. That's how I got paid. Every morning I would get a stat report. Each ER, how many patients we saw. That's all they wanted. Not how many patients went home and came back because we didn't take care of them right. Why does that not matter? It's a second bill, second day. You can bill the insurance company on a second day. You can't bill them twice on the same calendar day. As long as they come back next day, ka-ching, you got another click. So the incentives are totally wrong. We know that. So now, I'm going to talk about value for a second, okay? And I'll simplify. This slide is really meant for docs because they really don't get it. You guys probably get this a lot more. So value is really quality over cost, okay? If I got this suit from TJ Maxx, it's $50. It feels good. I like it. Quality's okay. It's $50. Great value. I'm going to tell you, go get the suit. But if I got this suit for $1,000, it feels good, it's $1,000, you're not getting the value. So, that's how you would define value of anything. Anything you buy, that's what you're doing in your head. Quality over cost. Anytime you look at the value of anything. So now, in healthcare, we need to remember one thing. We need to put access in there. Because on a Friday, you can have the best cardiology in the world, right? Quality's great, cardiology guy charges your normal rate, good value, great value. But on Friday at 8 o'clock at night, he's not available. What's the value now? Zero. So without putting the access piece in there, it doesn't matter how good you are, or it doesn't matter how good a service is. You can have the best service 9 to 5. People don't fall sick 9 to 5. They just don't. And so on top of access, what we need to do is probably put outcomes, right? Because you can measure quality all kinds of ways. I mean, you'll say, this is a good quality. How does that, what standards am I following? There's no standards. Everybody just says, I'm a good doc. What standards? So you want to do outcome. And if you can get outcome-based payments, you won this war. And I'll show you how in a minute. So when I say outcome, we're basically saying I don't care about the quality measures. I just want to know if you're going to operate on my knee, am I going to get an infection? Am I going to get a DVT? Am I going to get a blood clot? Am I going to have to redo this knee? If I have to redo the knee, are you going to charge me again? Today's world, you get charged again, right? But if I said, pay me once, I'll take care of your knee, now you got somebody that's really outcome-based. So reality is, I was talking to some guys that were saying, yeah, we do outcome-based. We have 0.5% infection rate. I said, dude, that's not outcome. That's an expectation. If I'm going to come to you, you need to have 0 infection rate, not brag about 0.5, right? I mean, it doesn't make sense. That's not outcome. Those are expectations that you're not going to get my knee infected, and you're going to wash hands between the other patient. That's an expectation, not an outcome. Outcome is truly to say, I own this knee. I will charge you X. I own it. So now you're going to get the best guy operating on that knee, essentially. So if you were to say, ask a surgeon, how long will it take for my surgery Monday morning on my mom, gallbladder surgery? You know what he's going to say? He's going to close his eyes for a second, think about who's operating on a Monday morning, which hospital he's going to be at. Is it going to be the A team or the B team? If it's the B team, it's an hour and 25 minutes. If it's the A team, it's 55 minutes, right? So it depends on who's there with you. Now, if you go to a orthopod who only operates, the entire hospital only does joints. Now, the tech, everybody is joint, joint, joint. No one's doing brain, joint, heart, everything mixed up. So now you got a different pattern. You got that Lean Six Sigma is in effect right now, basically, right? I mean, that's what you're doing. When I start saying, hey, we need to see what other people are doing, we need to always keep one thing in our minds, is whenever you talk to someone, is it outcome-based? If not, it's what we have today. If I'm going to say, I'm going to sell you this, it's $100, well, I can go to Amazon and get it for, $99. But if I'm going to tell you it's a lifetime $120, no matter what, I'm going to replace it for lifelong. Now you're talking my language, right? So that's what you need to shoot for, is whoever you talk to, is it outcome-based? This is about a year ago slide. So I said, what are the other employers doing? Because I'm not smart. I need to know what smart people are doing. So I said, the 10 largest employers in the country, you just Google this, right? So I made the pie chart because it was all over the place. So these are the top 10 employers. Of course, Walmart has 2.2 million. So my point is, what's the next question you should ask is what? What are they doing? Because Walmart's not stupid, let me just tell you. They got this down. So what are they doing today? Anybody knows what these guys are doing? Top 10 employers are out here. What do majority of these guys do? What's that? They're self-funded, perfect, yeah, of course. These are all self-funded. But what do they do in the self-funded environment? They got together and said, we want to do destination of care, okay? Or you can call it centers of excellence, whatever verbiage you want to use. What it means is these 10 employers, 70% of them, the green is 70% of these employers are actually having a designated hospital for surgery, for orthopedic, designated hospital for cardiac, designated hospital for belly surgeries. I mean, they took 5 top surgical procedures and said, we're going to go to they identified 5 hospitals, basically. And they negotiated the rate. Look at that. They went and negotiated the rate and said, if I bring my patient to your hospital and you're going to do the knee, I'll pay you $35,000. I'm not going to pay $55,000. If I'm going to do my heart surgery at your hospital, I'm going to pay $48,000. I'm not going to pay $100,000 in the city like I do in my town. So now you got economics covered, okay? What's the next piece? I said value. Cost is one piece of it. What's the other piece? Quality. I mean, you could go to a quack doc and pay him $5,000, but that's not what you want to do. So now, think about it. If you have a hospital that only does ortho, day in, day out, the orthopedic surgeon gets paid more per surgery, but the overheads are less. Complications are less. They get out of the hospital for, let's say, a knee surgery, for open heart surgery, let's say they stay in the hospital 5.8 days. Well, now at this cardiac hospital, they're going to stay 4.2 days. The cost is not the surgeon. The cost is all the ancillary stuff around the surgeon. That's where the cost is. So you can pay the surgeon more, and if you Google these docs where Walmart's got relationship built, these docs are top 10 to 15% tier in the country. So now you got an executive, so there's a Walmart across the street here probably, right? So if the greeter at that Walmart, when they need an open heart surgery, they're going to go to Florida. And they're going to say, if you go to Florida, we're going to cover all cost, and we're going to, on top of that, we're going to zero copay. So you got a greeter that says somebody with a white coat's going to chop on my knee at zero cost. I'm there, right? Now you have the executive at Walmart saying, wait a minute, Walmart never did anything for me in the past. Why today are they going to send me to, something's wrong. So that person, I would say, Google this doctor that's going to cut your knee. Google him, he's got the best reports. It's open, it's an open book. So now you got the executive at Walmart going to the same knee surgeon. So you're driving traffic, economics or quality. Both are the drivers. They started this in October 2012. What do you think happened next year? Exactly a year later, 12 months later. You think it worked? Yeah, otherwise we wouldn't be talking about it. It worked. Lowe's piled in and said, hey, this is a great idea, we're going to do this. And then pretty much in the next year, 14, PepsiCo, Frito-Lay, all kinds of other guys kind of went into this, all right, model, saying we want to do destination care because they have the volume. They have the mass. They know that they need so many elective open heart surgeries every year, we can divert that traffic. Obviously, I went ahead of the curve. So what were they thinking? They knew you could do a clinic, you can do wellness, you can do pharmaceuticals, you can do all these things, imaging, you can do all these things, and then you get to the ICU. So they went and said, we don't want to mess with this stuff on the left-hand side because it's sort of too complicated, too cumbersome to save $50 for an outpatient doctor visit. They don't care. They want to save $50,000 on open heart surgery because they can. Right? They can. They got the volume. So they went sort of like right in the tail end, the surgeries, and said, let's figure out how to save money on the surgeries. So now the question to you is like, why do I even give a damn? Right? That's what you're thinking right now. Walmart's doing whatever Walmart. None of you guys are going to get a job at Walmart. Nowhere am I. So we don't give a damn. But reality is, this is what we should follow, and we can. Here's why. Say, first of all, these are the savings from Walmart. So they're true savings. They're there. So what Walmart did was they said, I don't want to do standard of care. I want to do best care. I want to find the best doctors, the best care, and the best cost. You'd be surprised. The best care in the country is usually the cheapest care. It is. And I can show you that in a little bit. But it is the cheapest care. So if you find the best care, it's the most economical care on top of that. So you got both parts of the world covered. So what did they do? They basically went out and said, I want to find high-performing organizations. And in a healthcare industry, high-performing organization is something that really just came out about 10 years ago. You saw all these hospitals do Lean Six Sigma and the Toyota way and all these things, and they got all these guys engaged, and nothing works. They just couldn't embrace it. All right, the rest of the industry has been doing it for years. right? But they couldn't embrace it. But now there's emergence of high-performing healthcare organizations, and that's where this solution lies. So if you can identify the best surgical place for the heart, for the spine, for the joints, and all these other things that are high-ticket items, you could pretty much save your employers money, essentially. And how I look at this is, you know, a couple years ago we were talking about Obama plan, and then now the Trump, whatever he's going to do. Irrespective of what happens in the White House, they're moving the Titanic. Okay, it's going to take a long, long time to steer. These employers have it down, right? They're in speedboats. They can navigate the waters. They can actually see the target. You know, if you talk about DC, doesn't even know where they're going. They might get there and say, oh, well, we landed up on the wrong island. Let's go back and go to another place. So these guys can actually see the target. They're moving fast. They can navigate the waters and change directions in a heartbeat. They really can. So why will this help? Here's my take on this. If you guys have your own book of business, right? And let's say you take some of these book of business and you get together a huddle and say, what can we do to form a group, a sort of a branding under one roof that we can go negotiate. So you may have 5 cabbages, you have 10, you have 50, you have 20. Now you got 100 open heart surgeries that are being done a year with this group of individuals, even though you compete. All right? You may be competing for the same market, but at the end of the day, patients are patients, and if you put them together and you got one entity that has voice and then can steer these patients, you can become a baby Walmart, is what I'm saying, right? I mean, that's the reality. I mean, you're not going to be a Walmart, but you can become a 100,000 covered life pool that works as a bargaining power, nothing else. You can compete, but you can work as a bargaining power. Can you imagine what the hospitals in town will do? It'll say, shoot me here in the back of your t-shirt. That's what it'll say, and that's reality, but it's okay because you're doing the right thing for your employers. You truly are. This is a clinic, Henry Ford Clinic, 100 years ago, 1914. It was a clinic back then. Henry Ford went to Johns Hopkins and hired 2 doctors, put them on a train, said, meet me in Detroit. So didn't he have doctors in Detroit? It was booming back then with the automotive industry. He had enough doctors, enough money, they could hire somebody local. Why did he go to Johns Hopkins, get 2 guys, put them on a train? One of the best. What else? He wanted somebody that's not local, that's going to steer traffic the way it should be, and not because I golf with you, right? I mean, if I admit a patient through the hospital, when I do a consult to the cardiologist, am I going to put the consult for my competing cardiologist I don't like or the cardiologist I like? Right? I mean, it's so, this guy went out and got 2 guys and said, here's your clinic, here's the patients, the employees, take care of them. So it was basically an employee on-site, off-site, whatever you want to call it, clinic. So it's not a new concept. It's the oldest concept that exists before insurance came out. Because back then, the only people that got taken care of in terms of healthcare, if you worked for a big automotive industry back then everybody else kind of followed. So this was originally a clinic, I guess it's off-site, on-site, whatever that may be, but eventually it grew out and became a full-fledged hospital and insurance, and obviously it's no longer what it was intended to be. I guess, you know, you said, why did he go out and get 2 guys? He really got these 2 doctors to be the quarterback. These 2 doctors were not actually seeing patients. 2 docs cannot take care of Henry Ford population, right? Obviously. So these guys, he got them because they were using these 2 guys as a quarterback for all their employees, so that way they get taken care of in the community, and they come back and get them. So they collect the medical records, basically. You know, if you were to say who's got the best medical record system in the world today, what would you say? Or say 50 years ago, let's go back. In 1930s, 20s, who had the best medical records? The government. Why? The soldiers, why? They carried it in their backpack. The patients own the records, not hospitals, not electronic medical system. The patients own the records. So they actually carry their own records. So these guys were looking at how can I get these two guys to sort of navigate the care in the community. At that place was obviously Detroit. If you were to kind of look at what evolution has done, right, where we are on the clinic world, evolution is refined everything. So going back to the same house that we kind of illustrated earlier, on the left-hand side, remember we said it's wellness, that it's got a clinic, they got an urgent care, they got medications and all that. So if you start moving some of the stuff from the floor and put it on the right-hand side, right here, so basically now the patients are going here for some of these services, but then start moving these services out from the floor. Just start popping it out and make it into the right-hand side. Now suddenly, you're going to, a well-ran clinic today is probably going to save you about 9% on the healthcare spent. 9% on a healthcare spent. That's a good number. Operating word is a well-ran clinic, right? I mean, whatever that means. And these are real tangible numbers that people are doing in this industry at least. And I'm calling this clinic 1.0 because what's going to be 2.0? We just said all the things on the bottom is where the services are being rendered. It's disjointed. It doesn't talk. The ER doesn't talk to the urgent care doesn't talk to the hospital doesn't talk to the primary care doc. And they never will. Whoever tells you this is going to be fixed, they never will. Okay? That's by design, they will never talk. So unless you get single payer, then everybody's going to have to talk. So until that happens, when it happens, if it happens, it's never going to talk. So we're moving things out from the floor and trying to put it on the right-hand side. So what do you think the next evolution of the clinic is going to be? Move more stuff from the floor out. What can you move out? Can you move out clinic, primary care doctors? Yes, the answer is yes. You can start popping some of these things out. And as you start moving some more services out of the floor, now you created a savings and control of the care that's being delivered within this mix of population. And now you can see somewhere like 20, 22, 23% healthcare spent saved per year. That's now you're talking real serious numbers. People are going to listen. So now you're going to say, wait a minute, how is this going to help me? Because I have small businesses. I don't have large groups. Or what if you took all the small businesses, 50, 200, 200, 200, put them together on a table, and now suddenly you have 1,000 employee population that you can say, I can actually put a clinic now. It's no longer a small group. It's a co-op model with 5 or 6 other smaller size, self-funded employers. You can actually package that together. It's reality. It's happening. It's done. And how many of you guys rented a movie from Blockbuster? When's the last time you rented a movie? All right. So 1985, it started in Dallas. David White. 2 years later, they sold it for $50 million. Amazing concept. We all rented movies from there. We went and paid $3 at this place, or $4, and bypassed the dollar movie next door because of the ambiance, because of the popcorn smell and the music and everything in between. I mean, it was just nice service. They sold customer service in a brick and mortar, and they knew how to get the customers. Why do you pay $5 for a cup of coffee at Starbucks? It's they know what you want, customer service. That's what it is. You can go to McDonald's for $1.29. So you bypass the dollar movie rentals to go here. Over time, what happened to them? They went belly up. They went public, and they lost their CEO in 2007. 2 years later, they went belly up. So why? Why did they go belly up? Outdated, but who took over? What did Redbox do? What did Redbox do? They gave access. They knew we were lazy, right? I mean, if you have in your town, let's say you had 5 Blockbusters. Now you have 150 Redboxes anywhere you go, right? So they gave access. They knew this stuff, cold, right? Obviously, value, they put the word access in there. They didn't care about, so they gave access and people went. They'd rather go here than go to Blockbuster because they're only open certain hours, certain days, and It's not convenient. So what came next? Netflix. What was this? Why did they take over the market? Or will whoever's got stocks in Redbox, you should probably get rid of them. All right? I mean, it's not going to be there. So why is this going to take over? Or is? Really late. Couch potato. Define couch potato now. Right? You can just surf what you want. You can binge and watch all your shows in one spot. I mean, they really define access. So when I'm looking at access, we need to start thinking in healthcare without access, you have nothing. So whenever you start talking about services and what can you provide, if you're not going to give access on a Saturday, Sunday, that's where your cost is. Your ER visits on a Sunday night. Because they want to get better before Monday morning so they can go to work. A solid citizen, right? A solid mom says, I have a 2-year-old baby with fever. I think it's ear infection. It's a Sunday. If I wait till Monday, see my pediatrician is going to say, what on a Monday morning? Don't you know? Are you stupid? It's Monday. I'm not going to see you. Go to the ER. So the patient's pretty smart. The mom's a solid mother. She wants to work Monday morning. She gets the baby to the ER, gets seen. Everything's happy after an $800 bill. All right? No access. I guess Netflix is the thing, right? So now my question is, what's the next thing after Netflix? What do you think? Whoever today can come up with a platform, a technology platform that says, I will take Amazon, Hulu, and all these other, put them all together in one platform. So today when I want to watch a movie, it takes me 10 minutes to figure out where am I going to go pull a movie out. It's insane. That's 10 minutes. But if you gave me one membership for $50 a month and I get all with one button, I don't care where it comes from, just give it to me. Right? That's the next flick. So whoever wants to jump on it, I mean, I'm telling you, that's what's going to happen. All right. So access to care is, the rest of the world gets it. We need to embrace this. So this is the ultimate access to care in my mind. All right? It's simple. I never want to use the word cheap. It's simple. It's economically viable to do. They draw blood. They see the doctor. They give medications. But one thing you will never see or has ever seen in this place, what's that? Actual clinician has never stepped foot in this clinic. It's all remote. So you have a nurse that connects the patient to the doc. The nurse will give the antibiotics. The nurse will draw the blood if needed. So you got a nurse at $15 an hour with benefits, $21 an hour. With the rent, with the overhead, it's less than $6,000 to $7,000 a month. This clinic supports 400 employees. It's very functional. That's ultimate. So again, access to care is not a new concept. It's not a new concept. Question, or do I have 5 minutes? The thing is, this is basically telemedicine. I mean, this is what access to care is. It's we were afraid of it. First of all, telemedicine is not new, guys. It's been around for 25 years. And the 25 years it's been around, why didn't we see it till 4 or 5 years ago? What was that? We have the best technology. We send people to the moon. It's 69. We have the best technology, better than anybody in the world. So why didn't we see it earlier? Regulation. No money. The government, CMS just passed last year, 2015, that we're going to start compensating you for telemedicine services based on certain guidelines. So now, guess what? People are getting paid. If there's no money, there's no mission. You're not going to get anything done. So the point is, until recently, we weren't being compensated. So telemedicine, why bother with it? It's a waste of money. I'm going to read this. This is pretty interesting. This is 100 years ago in a magazine, Science and Innovation magazine. It says, a busy doctor 50 years hence will not be able to visit his patients as he does now. It takes too much time. He can only, at best, see limited number today, whereas the services of a real big doctor are so important that he should never have to leave his office. On the other hand, patients cannot always come to see him. It says it all, right? This is 100 years ago vision. It's not new. Look at this guy. He's actually doing like a robotic surgery here, and like Da Vinci robot. That's what he's illustrating 100 years ago. It's impressive. When I was with the C-suites at the hospital, I figured out what the fear was. You know, everyone has a fear, right? Like you always go to work and say, what's going to be my last day? Like, what do I have to screw up today that the CEO is going to come say, Patel, you're out? It can happen. You need to know, right? It's true. I get a check. I need to make sure I don't screw something up. So I soon realized that the fear is anybody in the C-suites, the fear is who? The competing hospital, right? If I'm ever caught with a competing hospital at a restaurant or a Starbucks, I'll probably lose my job that day. Okay? So they fear so much of their competition, but what I kept telling them is they should be your ally. You should start your Monday morning with the CEO across the street in that same Starbucks to figure out what services are you doing, what services am I doing, and can we capture the market? Guess what's happening in the town where I was, where there was 2 hospitals? What did Walmart do? They took away all the paid surgeries that were top payers. We no longer do knees, open heart surgeries. We no longer do spine. Why? Walmart took it out. Lowe's, what happened to Lowe's? Same thing. What happened to Pepsi? So we should have done, the 2 CEOs should have gotten together and said, what can we do to keep these people here? Can we become the centers of excellence for knee surgery? Instead, they were competing and all these paid services went out. So guess what these 2 guys are doing now? They're seeing junk. When you need an open heart surgery right now, at 2 o'clock in the morning on Sunday, we're doing it. Elective surgery, they're going somewhere else. So what I will say is, what is your fear? Right? I mean, we all have fears. So what is your fear? Is that you're competing with her and she may take your clients or vice versa. But reality is what we should be fearing about, it's what's happening in the hotel next door. You have your small, fully funded employers next door right now talking about how to form a conglomerate to get what? Better deals. You think I'm kidding? This is happening right now in this town, every town. So you should be in front of that stage and saying, let me show you how. This is not as easy as you think. I got the tools. They're looking for that, but no one's offering, so they're doing it on their own. So what we should be fearing is that, not who's competing here. Because you'll compete all day for the same market share. But those employers will then take those patients and ship them out of your zip code, and you're done. I mean, that's going to be history. That should be the true fear. So I guess when I'm starting to look at what can you do, right? I mean, what's in your sort of hands that you can do? You gotta, whatever services you're gonna look at to provide or improve to your employers, you have to look at how am I going to make this employer, this patient population, the employees and the dependents, give them a true primary care doctor. When I say true primary care doctor, I'm talking about a quarterback. I'm talking about somebody that knows every play. Today, a primary care doctor knows nothing. You know why? Because they'll go there for a flu shot and for diabetes, and then they go to the cardiologist and the neurologist and the pulmonologist that does all these things, and they get prescriptions filled at 3 different places. They don't talk. You think CVS is going to give information to Walmart? And Walmart's going to give information to Walmart? Never. So unless you shop at the same place, you're not going to share prescriptions. Not every patient shops at the same place or the same system. So now you got medication errors contributing to the 3rd leading cause of death. Unless you create a true quarterback, you will never go anywhere. That's probably your step 1. How you do it, details in the devil, but the devil's in the details. But the point is, that's probably the first thing you need to focus on. Then, we've always used the word clinic. It is not a clinic. It is a place where patients come to get everything done. It's not a clinic in the true sense clinic. So somehow you need to re-verbalize this, re-message this to say it truly is a medical home. You're not just saying, here's a flu shot, go home and go to your pulmonologist. You want to control the pulmonologist. You want to know when they go and get those records into that system, the medical home. Identify high-performing organizations. They're easy to do. It's not that complicated. You know why? Copy what others have done. So Google all the big employers and find out where their destination of care is. Call them up. You think they're going to not want to talk to you? You tell them you got 100,000 covered lives. What do you think they're going to do? They're going to buy you dinner tonight. All right? But you got to get together and create that pool. And I can share all of these slides with you guys. I'll give you my email. I'll shoot them out tonight. So you don't have to write anything down. Now, you are in this world where your employers have several different vendors probably. One does wellness, one does screening, and one does this and that, maybe 2, 3 vendors. I guarantee you, give me hands that say those vendors actually talk. Right? None. So unless you find the vendors that can actually share data, and there are guys who do, it's not going to work. I mean, you could get a wellness, I kind of laugh at the wellness. You know, people say, we got a wellness program. Wow, what do you have? Nothing. All you do, you get a patient that's 30% overweight, diabetic, smokes, sedentary lifestyle, they check, get a $50 gift card because they filled it out, and then they come back and say, you're fat, you need to lose weight, you need to stop smoking. Well, he knew that before he came in, okay? But the point is now you got to take that information and throw it into the pool where your clinic is. Not the clinic, the medical home, and give it to the quarterback that says, I know what to do, I got it, thank you. I'll take it from here. So if your vendors aren't talking, all you do is wasting money, their money. And unfortunately, unless they talk, unless they actually share true data, it's not going to happen. And the last thing on this list is destination of care. And when I say destination of care, we're talking about, identify high-performing organizations. And they're there, they're out there. My thing is this, you can get this list from Borders, right? Ideas are available in a bookstore. The key thing is, how are you going to execute this? I mean, that is, you can plan all day, but execution is going to be the biggest piece of this. How are you going to coordinate all of these pieces together and make it work? So if you think about it, Walmart started on bottom up because they could. They had the volume. They didn't want to piddle with the little stuff. The $100 savings here and there with primary care, they didn't want to piddle with that. But you need to start piddling with that stuff and this and meet everybody in the middle. So guess what Walmart's new mission is? They're going uphill. They started on the bottom. I mean, when I say bottom, in a good way, they started at destination care, high-ticket items, 5 surgeries. Now they increased the surgical centers. They doubled it in the last 24 months because of their success and because the people are actually going and using these places, and they're going up the ladder. You're going down the ladder because we don't have the bandwidth. But either way, now they're looking at, when you say Walmart has those clinics, that's just an urgent care. It's not a clinic. It's not a clinic for their employees. It's a clinic for consumers. So you'll go in there, get your sore throat fixed. They'll give you the antibiotic prescription. Guess where? At Walmart. It's called in their electronic medical record because they talk, and they'll delay it for 45 minutes, so you're going to go shop for stuff you never needed. Let's talk about a couple of things. First of all, we talked about standard of care, right? I mean, that's where we are today. We talked about how can you deliver best care. That's what Walmart's doing. That's what we should be looking at, is how can we do the best care. We talked about Netflix, what's next. So here's what's next after best care, in my mind. It's right care. Right care is what we should be striving for. But I'm telling you, it will never happen. Okay? But at least we should know the fantasy world. All right? It's nice to just fantasize for a minute. So let's say standard of care is spending 5 minutes with the patient. The best care is spending the quarterback an hour with the patient, 40 minutes with the patient, 2-3 times a year. What if we spent 3 hours with the patient per month? Is that doable? Do you think you can improve care at that point? Do you think you can change behavior? Do you think you can have people stop smoking? Do you think people will start losing weight if you spend a couple hours with the patient? I'll give you an example to illustrate the right care, because it's hard to fantasize, right, without a story. So let's say you have an 80-year-old who basically is hypertensive, diabetic, okay compliant, gets mini strokes, is on a blood thinner, has a couple of mini strokes, and finally has a stroke that bleeds in the brain. So now you have a bleed that you can't operate on, it's never going to stop. So they make him hospice. What else are you going to do? You can't do anything. You can't stop the blood thinner because then the heart's going to throw another clot. So you lose either way. So he gets pulled out of the hospital to go home and die. It just happens that the home, there's the doc that's part of the family. So guess what happens to this guy? In the next 3 to 4, 5 months, he's right-hand dominant. With his left hand, he's popping 8 bags, sandbags in a row. 8 in a row. I can't do 8 in a row. I'm telling you, 8 in a row. It's not like clip. So what I'm driving at is what happened. So this is my dad. So what happened? I'm not smart, not smarter than another doctor. I just gave him time. I didn't do anything. He was on 13 medicines. I cut him down to 3. Why? Because the other doctors were poisoning him. With 5 minutes of time, when my dad says, my elbow hurts, here's naproxen. I got a rash, oh, here's another steroid. So everything had a pill. Today he's on 3 pills. That's the right care. That's what we should be shooting for, not the best care. Then you can maybe fall back a little bit and you still will be ahead of the curve. So it's the time that solves all problems. It truly does. In this world, in this medicine world we're in, you give me time. I can take care of 2, 3, 4, maybe 10, maybe 20 patients like that a month. I can't do 50. I don't get paid enough to spend 3 hours a month on a patient and take care of 50 patients. I have to see 3,000 patients, right? A panel of 3,000 patients. So, but the point is, that is what really is, that's why I say it'll never get achieved. You can't do it. But it is not how smart the doc is, it is what we went to school for. It's just time. You give me enough time with a patient, I can make magic happen.